Good morning, everybody. For those who I haven't met, I'm Ian Venamore from Brisbane, Australia. I'm here with my beautiful wife of almost 50 years, Judy. And I wanted to share a little bit of my story with you first. I was diagnosed first in 2003 with moderately severe emphysema, chronic obstructive disease, pulmonary disease. At that stage, I had a fairly demanding job. I was busy, and the symptoms were so subtle that I didn't really appreciate the extent to which they could decline. And so, until 2009, really, 2010, it finally made my decision up for me that I should retire, and it was time for me and my wife to enjoy life. And if I let it go any longer, who knows? My only sad remembrance is that probably I should have bitten the bullet earlier. But having said that, I managed to do pulmonary rehabilitation at Royal Brisbane with a dedicated group of people. They inspired me. At the conclusion of that particular rehab, I was bussed down, or the whole group was bussed down to the local YMCA, and the purpose of that was to introduce everybody to maintenance exercise, maintain the gains. And of course, that was 2011 by the time I'd completed rehab and started the gym, and I've got to say I've never changed. I haven't stopped. Allied to that was my decision to investigate as much as I could about the disease that I have, its impact on my life and my wife's life, and came in contact with the Lung Foundation Australia. So really I'm here today representing myself as a patient, but also as a proxy, as you might say, for Lung Foundation Australia. I volunteer with them and have done since 2012. I've been involved in maintaining databases for both pulmonary rehabilitation programs and also for patient support programs. And I was asked by Liz Harper, who's the director of the foundation then, if I would do this little job for her. She has a winning way with words, Liz. And 6 or 9 months later, I said, well, I've finished that one. She said, well, I've got another one for you. How about, would you like to talk to the rehab programs and bring us up to date? Because we really don't have the manpower. We do a lot with very few permanent employees. I think there's 19 throughout Australia. So I said, okay, I did that. And of course, 12 to 14 months later, trying to get clinicians on the phone to talk to them about this was a big issue. So I'd completed that. And from there, I was asked by Heather Allen, the CEO, to accompany her, Christine Jenkins, Kirsten Phillips, the new director of the COPD program, down to Canberra. And I might share with you a couple of slides. This is probably a combination of slides, some of which form the presentation to the politicians in Canberra. And the purpose of that particular trip was to further our aim to develop an MBS item number and gain acceptance for an MBS item number so doctors could prescribe COPD rehabilitation, pulmonary rehabilitation. At the moment, that's provided by usually state-based hospitals. We have a state health system and a Commonwealth health system. The Commonwealth doesn't provide that funding for pulmonary rehab, the states. There are some private ones also, but by and large, they're provided by the larger metropolitan and regional hospitals. In this photo, you can see myself with Judy and our youngest and last grandchild, 4-year-old Liam. As I said, my rehab has enabled me to do things as much as I wish I could with young Liam. He'll be our sixth and last child, a grandchild. So this is the advocacy process for Canberra. Just by way of background, here are the way the structure of the Lung Foundation is. We fit in, let's go back. We fit in where the COPD national program is. There's a group called CPAG, and most of you may be aware, patient advocacy group, which reports to the director of the national COPD program. As you can see, we have other streams for other lung complaint and rare lung diseases, etc., the IPF. But we report to the COPD national program. Now, the things we make in Australia, of course, they're probably no need explanation because everybody's aware of them. But we're also not bad at making prime ministers. We've changed 4 of them in the last 5 years, so we've done a pretty good job of that. But there are some pertinent facts here that we should be aware of. In the Australian context, 1 in 7 Aussies over 40 estimated to have or will have COPD during their lifetime. I haven't bothered with attribution for evidence because that, for brevity and clarity, I've left that out, but it is available. It is the second leading cause of avoidable hospital admissions, as at 2011-2012. In 2012, it's the 5th leading cause of death in Australia. A single hospital admission for COPD without complications is around $5,000. Pulmonary rehab, by evidence, reduces hospital admissions and average length of stay. Basically, what they're saying here is that for the cost of 1 day, one night in a public hospital, you can provide pulmonary rehab for 4 people. And as a patient, told all our stakeholders and politicians in Canberra, it improves patients' quality of life and keeps people out of hospital. And there's one of the most succinct phrases I think I've ever heard. It sums it up aptly. It is funny that you never think much about breathing until it is all you think about. That's a keeper, that one. Early in the disease progression, physical activity is reduced, again, supported by evidence. And then we have the disability spiral, beginning with fear of breathlessness, avoidance, decreased ability, decreased coordination, muscle weakness, breathlessness, and so on, so on. So pulmonary rehab is, as we all know, an evidence-based intervention to improve quality of life for people with chronic lung disease. The structure of pulmonary rehab in Australia, as it stands at the moment, it's pretty much standardised. An 8-week program which comprises exercise training, education, a pre-assessment, exercise training, including education, and then post-assessment. And critically, and most importantly after that, is the maintenance exercise. And it's actually provided by an experienced team of health professionals. Why is it so important? The 2 big issues we pushed in Canberra were that it improves people's quality of life and it keeps people out of hospital. The politicians love to hear that. It keeps people out of hospital. So the patient reasons, obviously, reduces symptoms and breathlessness, improves function and strength, etc., etc. And for the health budget reasons, it reduces hospitalisations, reduces inpatient bed days, reduces mortality, started after hospitalisation, and reduces healthcare costs. It's been found to be the most important non-pharmacological intervention for people living with chronic lung disease. Depending on the patient, benefits can be sustained for 6 to 18 months, and further extend the benefits by continuing with a supervised pulmonary exercise program. The barriers to access, although it's not shown in the slide, the those reported cases of asthma are a lot lower than those that you see for COPD. And that all comes back to the fact that it's not the primary caregivers in most cases that are diagnosing this. It comes down to doctors who either can't or don't. And this is why the importance of being able to provide an MBS item. An MBS item being simply an item number that the Commonwealth Government will pay the practitioner for to diagnose the disease, and then that can be extended outside the greater regional centres, and what we have at the moment is 750,000 patients in 260, it's now 273 programs throughout Australia, and service only 5% of these patients currently can access it. And this is all about the tyranny of distance in Australia and a lot of other access issues. Most are hospital-based, long waiting lists, transport and parking issues, limited access, etc. There's limited resources and awareness in primary care. And there's limited awareness amongst patients. There's a diagrammatic, if you will, of the distribution of pulmonary rehab, which pretty much mirrors the greater population centres throughout Australia. As I said, there are 273 of those, and there's approximately 160 patient support groups. The patient support groups fill an important role for carers as well as patients. So the solution was, to the politicians, we said that we were looking for a benefit of $55.25 for the pre and post assessment, the rehab service to be a maximum of 16, group service to be complete within a 10-week period, $21.25, and a pulmonary maintenance exercise group post rehabilitation, maximum 16 group services within a calendar year, benefit $8.50. Currently, we're going through the MASC and PASC process, the acronyms being medical service, it should be MSAC, Medical Services Advisory Committee, and PASC, which is, beg your pardon, I've lost it. PASC, I'll come back to it. Lung Foundation have been working on this since September 2014. We submitted a pilot submission and an MSAC application, which is basically an application through the Department of Health. And I'm sorry, PASC is, well, I've lost the word again. Let's start again. On February 15, we accepted for protocol development. Thank you, protocol development. That was the clue I needed. Protocol Advisory Subcommittee. So when you're dealing with government, you're dealing with lots of acronyms and lots of complicated procedures. On February 15, we accepted for protocol development. June this year, the protocol was drafted and submitted. In August, we had the subcommittee meeting, a review and feedback. September was the Parliamentary Friends Advocacy meeting. And of course, as we couldn't have timed it better, as it turned out, that was the very week that Tony Abbott got kicked out of Parliament. So our meetings with his health advisor and the Treasurer's health advisor were cancelled because of that. But fortunately, we were able to speak to many others, including the Finance Minister and the Minister for Health. Seeing the sort of evidence that was promoted to them, it was pretty hard for them to say, look, you don't have a case. So now we're on to the economic evaluation. So that's at the process where we're gathering all our resources to lobby the government through the local members, through any contacts you have, to push the case for this. That's what they're looking for, a committed response from a wider group. We expect that it gets through MSAC within the next 2 to 3 months. It'll then go back to Protocol Advisory Subcommittee. They will then send it to an economic committee for evaluation, further evaluation, and from there we go to provision and budgeting. Now that could take, and we expect it to take, another 12 to 18 months. But how can people help? These points keep being hammered. It's evidence-based. It does and will keep people well and out of hospital. It will save healthcare resources, and more patients need to access pulmonary rehab and pulmonary maintenance exercise. That's pretty much all I have to say, other than to say that I'm happy to copy this presentation for any of you who wish it. There are some interesting links to some of our current advocacy programs, having the chat, which involves talking to patients about coughing more than usual, harder to breathe, any change in sputum, colour or volume, and tired more than usual. To wake people to be aware and get to know their body, and if they do see any of these increases or any changes, to talk to their healthcare professional as soon as possible. The other two is, one is Quit for October. As you know, probably Australia has some of the toughest anti-smoking laws in Australia, so much to the point that the big cigarette companies have given up on Australia. It's too small a market. We'll go somewhere else like the developing world where we can clean up. But plain packaging, both here in New Zealand, even to the extent of prisons, which I never thought would happen, and within 3 metres of a doorway to public buildings, to restaurants, and even to alfresco restaurants, it's even a wider barrier line. The other program is Just One Breath, and this is an inspirational one which we put together with some high-profile people you may have heard of. Christine Arnoux, the singer, and who else do we have there? Oh, Casey Delacqua, the tennis player, and a number of others. And it really took off because people treat it like a piece of art. So I encourage you to look on that website, follow that particular link, that hyperlink, which will take it to you, and you'll see some of the beautiful work that was done, all in support of the Lung Foundation. I feel very privileged to be a part of that, part of CPAG. Long may they continue. They're fantastic people, compassionate, professional, and always friendly. Their people and an organisation provides such handsome social dividends. I think any country would be proud to have it. That's all I have to say. I can say that I brought some printed resources that you're welcome to take with you. Of course, I couldn't bring enough for everybody, but I'm happy to provide a copy of the presentation so that you can take it away with you. And anybody who wants to know more, I'll be here for the rest of the day anyway, so I look forward to talking to you. But thanks very much for your time.